So this is a young guy like me who 30 years ago was like Dr. Mukhi and has been very stringently following Mukhi Asan, but not getting better for the right lower limb radiculopathy due to L5S1. And he's also met the charming Preeti, and her block has also not worked, which was given in the right place. He had partial relief of it, but the symptoms have come back again, and he's an athlete and just not getting better. So these are the cases where disabling symptoms with a compressive pathology are the ones which will require surgery. And for symptom relief, the only thing that you need is a discectomy. You just have to bring out that offending fragment of disc which is irritating the nerve root, and that will really settle all the symptoms for these patients. Yes, there are pros and cons of doing a surgery versus not, but for symptom relief, what is needed is that offending fragment which is pinching the nerve root has to come out. And this bringing that fragment out has only two parts. One is the access part of it, where you go through the skin, through the muscle, reach the bone, do a partial hole in the bone, do a laminotomy, oblique a laminectomy, depending on how big a disc fragment is, and then do a definitive surgery of bringing that fragment out. And how do you do this? How do you achieve to do the soft tissue part of surgery or the bony part of surgery to bring that fragment out? That's the one that brings in the variations of surgery. It can be an open conventional laminectomy like Dr. Gautam mentioned 30 years ago our seniors were doing, or it's something that Dr. Samir Dalvie has propagated when he came back and Dr. Gautam we started doing it, and micro-lumbar discectomy using microscopes and conventional Maculox retractor, or versus what recently the young guns like us are doing using tubular retractors, what is microendoscopic discectomy using microscopes and same principles, or something that is now currently in vogue because of the USP of smaller incisions like endoscopic discectomies. Now, we all know the downsides of doing a conventional laminectomy, bone removal, and then doing a discectomy, which is associated with morbidity purely because of the access. It is the muscle damage that is done by a large skin incision versus a muscle dissection, which bring in more morbidity to the patient, particularly when the patient is having a very high BMI or patient is very obese, or for any reason the muscle dissection results into a higher blood loss, more pain, and more longer recovery time. And because of these downsides, there was this inception of a brilliant technique, which till today is the gold standard of doing any disc procedure, which is microscopic discectomy, which just entails retracting only the symptomatic side of muscles, reaching the bone, doing a small foraminotomy, laminotomy, reaching the ligamentum flavum, going to the offending disc, bringing the fragment out. And it entails only a small incision with very minimal blood loss and gives brilliant symptomatic pain relief to these patients. The scar is also minimal. However, the incision is midline and the muscles need to be dissected from the spinous process and the lemon out there. There were some downsides to this procedure also, and it is not something that is reproducible in the high lumbar ones or in the thoracic or in the cervical spines, which also led to inception of newer technology using further more precise instrumentation like cylindrical tubular retractors, which is also called a microendoscopic decompression. Believe it that it's not an endoscopic procedure now. However, when it was born like a endoscopes through these tubular portals, and that is why the name or the terminology that it's a microendoscopic decompression using microscopes going through special tubular retractors. The difference here is that here the retractor type is different. The incision is paramedian and it goes through the muscle planes rather than stripping the muscles periosteally from the bone. It goes between the muscle fibers, reaching and doing the same job after the access part of surgery is over. And then endoscopic discectomy, where the incision size is lesser and follows the same principles as tubular ones do, where you go through the muscle planes without having to strip off any amount of muscle, further reducing the muscle damage and the skin incision that is required. Again, the surgery part of it, the definitive decompression discectomy part of it, bringing the fragment out, that definitive surgery, which actually brings pain relief, remains the same. It doesn't change at all. And the technical differences are all about how you do the access part of the surgery. The definitive part of the surgery, which entails removing the offending disc fragment, remains the same. However, whichever technology, whichever technique you use, the definitive surgery just does not change, because if that changes, the outcome will surely change. So remember that the indications of surgery are a disabling symptomatic patient with a compressive pathology who has been counseled about pros and cons, and there is an excellent clinico-radiological correlation. Unless and until all these criteria are fulfilled, no matter what technique you use, the most advanced technique will 100% be a recipe to disaster. What to do? Again, the principles of discectomy or the surgery just do not change. You have to bring the offending fragment out, and for that you have to do access surgery through the skin, soft tissue, muscle and bony removal to reach that offending fragment. Sometimes if there is a concomitant lumbar canal stenosis, you may want to add a decompression surgery on ipsilateral or contralateral side as well. And the steps to these surgeries are fairly simple. As we see, the step 1, 2, 3, and 5 remain same. In any technique you do, the positioning, the planning, the level marking, it has to be absolutely precise and same, which we will see in detail also. However, the only thing that differs, the technical differences between the surgery, as the topic mentions, are all about where the incision is placed, how much muscle you remove, how you reach to that offending fragment area, and how you come out of it. And all this depends on how minimal, how least of damage you create through the access-related surgery. Further, coming to the principle of primum dinosar, do no harm while you're bringing the surgical trauma to the patient. The planning entails knowing about the patient's anatomy. We all know about the ligamentum flavum, spinolaminar junction, spinolaminar line, and of course nerve roots. Nobody can really predict the nerve root anomalies, but you should always try to make a note about a thick nerve root seen at a particular level on an MRI scan, which can give you a bare idea that you are ideally dealing with some kind of anomalous structure out there. So these are just some drawings to represent the spinolaminar line, because this is that one junction that all of us must be aware about. That's the area where your bony resection starts, and that's the amount of bone that you have to remove to reach the offending disc fragment out there. And that's when the traversing nerve root will come into picture there. Now, planning does not entail only about the normal anatomy of the patient, because all these are micro procedures, but also entails about variation that can come, and also about the pathology. Like in a migrated disc, though you may be reaching here, but the fragment has gone up. So you must be aware about it. And this has to be done preoperatively, even before you wash up. And this is something that does not change in what technique you go, whether you go up migrated or you do a down migrated, or you do a paralateral, or there is an associated facet cyst, must be planned, seen, and so that you are pre-armed and pre-warned and pre-alarmed already before you wash up for the surgery. There are various type of positionings. I generally use a vertical bolster from shoulder to iliac crest. There are people who use horizontal bolsters, but the principle is that it should have a normal lordosis, and there should be a facility or availability of something where you can get a change of lordosis if you want to do more decompressions out there. This is one of the patient where 140 kg obese patient. Imagine in this patient, if you had to do an open surgery, how big an incision you would want to do. So we are now lately been using Jackson tables to further free the abdomen, reducing the blood loss also in such patients. Now, level marking, false surgeries or wrong level surgeries are extremely common. If you feel that you're really good in avoiding wrong level surgery, it's a myth, because wrong level surgeries can happen to you like tomorrow, unless until you follow all the principles of following it, so that you don't have a wrong level surgery. It can easily happen, particularly in these micro procedures. So not only pre-operative marking is very important, but also intraoperative confirmation, and also corroborating it with the pre-operative MRI and the intraoperative levels and the one that you have seen on the C-arm. All this should come in with a confirmation from your team to really avoid any wrong level surgery. This can easily happen, particularly when you're doing a microdiscectomy procedure, because your needle level marking pre-operatively may actually be a different one from what you see on the C-arm. So this is a word of caution we all must practice very, very stringently. The only thing that changes in microendoscopic discectomy is that they are all C-arm guided procedures. The best part about tubular or microendoscopic discectomy procedure that they are all C-arm guided procedures. So the chances that you will go wrong or do a wrong level surgery are very minimal, because right from the point of marking the level to your tube going and sitting on the spinolaminar junction, all happens under C-arm. So there are so many shoots happening in around there that you really have to be a moron to be doing a wrong level surgery with a microendoscopic tubular surgery. Now, the incision and the retractor placement for a microdiscectomy is nothing but your interspinous area is where the hook goes. So this is that retractor which actually is used in doing a microdiscectomy procedure, which has a hook and a blade. And the hook goes on towards the interspinous ligament between the two spinous processes, and the blade part of it goes towards the muscle. So after a skin incision, which is the midline one, you have to retract the muscles, subperiosteally dissect them from away from the spinous process and the lamina, and the blade then holds it there, gives you a clear vision of the bone to remove a laminotomy defect into the ligamentum flavum, and that's when you reach the offending disc fragment, which brings out. Of course, during this, the principles of handling the nerve root remains what they are in any kind of surgery, which has to be bare minimum to avoid any post-operative neural paresthesia. Now, microendoscopic tubular decompression entails doing the same surgery, however, with the help of tubular portals, and the incision is not midline. It goes paramedian. As you see there, it is not in the midline. And the advantage is that you don't really have to strip off the muscles from the spinous process or from the lamina. It goes through the muscle planes between the nerve fiber, and this results into, with the help of serial dilatation of the retractors, prevent denervation or muscle damage, and then with the help of these tubular portals and microscopic technique, which helps you to have the vision of the bony area where you have reached down there to do the same surgery as you do in microdiscectomy. And this is how your tube duct looks like, and the vision, light, and illumination and magnification can then be achieved to do the same surgery as we do it in microdiscectomy. This is the one bony landmark that really comes crucial, and that's called spinolaminar line or spinolaminar junction, where all kind of surgery starts, particularly when it is all about microendoscopic tubular decompressions there. Now, once you have reached there, the surgery is the same. Once the access part of surgery by either a retractor is done, you just create a laminotomy defect. You remove the ligamentum flavum by dissection there. The one thing that you come across, the first thing, is the nerve root, the traversing nerve root, which is actually pushed more dorsally by the compressing paracentral disc herniation out there. And what you have to do is use your patties or cottonoids to get more medial retraction of the nerve root rather than using a nerve root retractor. In this process, you have to ensure that a decent amount of bony removal is done, because too less of removal will mean that your nerve root retraction is more, and too much of removal will lead to a pars injury out there. So this is one thing that can easily happen, particularly when you are doing a micro procedure where the whole amount of pars may not be actually visible. So the optimal amount of bone removal to prevent too much of nerve root retraction, and also optimal enough to not do a pars injury, is something that is very important, particularly when you are doing these micro procedures, and iatrogenic injury should not happen neither to the bone nor to the pars out there. So the video that is coming up is all about doing the surgery from the right side of the patient, where there is a right-sided symptom, right-sided disc herniation in this patient out there. Surface marking is imperative. You really, before your incision comes, to keep your incision bare minimum and your level marking. So what I do is I generally put in a needle there and do a check on the C-arm, as you see the needle out there, and then your retractor gets placed out there, which is again confirmed intraoperatively. Midline incision, midline dissection of muscles from the spinous process, base of the lamina, so that what you see, first thing, the hook goes into the spinous space and the blade retracts the muscle there. That's the head side, the foot side, surgeon standing on the right side symptoms at L4-5 level. And the first thing you come across is the bony thing. That's the spinolaminar junction. Please pardon me for the video output out there. So you just clear out the interlaminar space. The first thing you come across is the yellow ligament there. I do a partial laminotomy all the way to release the ligamentum flavum from the superior attachment under the lamina. And this is all happening after the muscle has been dissected from the spinous process laterally. So you go through the incision in the fascia in midline. Your skin incision and facial incision is in the midline. Your muscle retraction happens there. The multifidus is retracted with the help of a blade, and the interspinous area gives you the force, or the liver, where the retraction is through the hook in the interspinous area. After your ligamentum flavum dissection is done, the gray thing that you will see now is the dural surface. Piecemeal removal of ligamentum flavum is then done, and that's the dural structure there. Enough amount of bone is done to avoid really the retraction of the nerve root. Inferiorly, the release of ligamentum flavum from the superior aspect of lamina is then done. Once the ligamentum flavum is out, the only thing that you do is put a patty up there in the shoulder, put a patty down there in the foraminal area, and the nerve root automatically gets retracted out there. The only time when I really use a retractor, nerve root retractor, metal retractor, is when my blade is coming there to prevent any kind of blade movement related injury to the nerve root there. Lateral recess decompression can be done by curved forwards. One patty up and one patty down gives you enough retraction without actually having to handle the nerve root at all. As you can see, the whole disc will be in front of you, which requires a cruciate nick to the annulus before the fragment, the offending painful fragment, can be then brought out. Bipolar can be used to achieve hemostasis if there is any epidural. And that's the disc fragment out there, and a nick out there, and it's a disc that just pops out. This is the only place where a nerve root retractor is used to retract the nerve root. A cruciate plus or cross incision on the annulus is good enough to bring the fragment out. Before you really pull it out, I would like to dissect it out with my nerve hook so that all the fragments are out and there is no residual fragment that is left out there. So that ends your discectomy surgery. However, even with this, you can actually do a contralateral decompression using the same retractor if there is a contralateral facet cyst or a stenosis on the opposite side. And the nerve hook then palpates, the nerve root just falls back, your patties come out. And this is just a view that you can actually go on dorsal surface of the dural sac to reach the opposite side if there is a lumbar canal stenosis to actually see the opposite side as well. Now, the advantages are plenty. It gives you a very small incision, and all the advantages of minimal invasive spine surgery can be achieved by this microdiscectomy procedure, which has stood the test of time for more than 3 decades. And even today, at times, I would just do it. In fact, if my tubular set is not ready, I have absolutely no regrets in doing this procedure out there. The problems here are that it's a midline incision. It's a midline removal of the fascia and it's retraction of the muscles there, which can be bypassed. And sometimes even in osteoporotic patients, when the retraction of the maculus retractor is more, the spinous process may break or the interspinous ligament breach can happen, which further reduces the benefits of MIS because a breach in the posterior tension band can result into pain, particularly when a spinous process fracture in osteoporotic spines, which can happen there. And this can be avoided, and all the disadvantages of microdiscectomy can be bypassed using a microendoscopic tubular dissection surgery, where you have a paramedian incision and with the help of guide wire and then serial dilators, which results into dilation of the muscle without having to really strip off the muscle. There is no need of actually stripping off muscles from bone. You directly land on the bone out there and do the same surgery that we did out there. I generally use a 16 millimeter tube, but you can actually start, when we started was with 22 millimeter tube, and the depth can vary upon the depth of the patient's back to the bone distance. And the advantages are plenty. It is not only a dynamic procedure where you can use the same incision to do 1 level, 2 level, even 3 level decompressions. You can achieve the same advantage, the same amount of incision. The incision size does not changes no matter how obese a patient is, no matter how many levels you are doing, whether you're doing ipsilateral, contralateral decompression. Even in the most fat patients, you can actually have the incision size to be as small as 2 centimeters in all patients. And the technique can then be utilized in patients not only in lumbar spine but also in thoracic spine, in cervical spine also we have been doing the same procedure. So this is just again on the right side only we are doing the same procedure. We have just docked the tube on the spinal lamina junction. I'll quickly rush through it. That's the spinal lamina junction, the base of the lamina. And you do the same procedure out there. Once your vision is clear, your bone is seen. Sometimes you can use a burr, the ligamental flare is seen, and you do the same procedure as it is done ever. The advantages of this procedure are that you do not have to really go through midline and you don't have to take the fascia away from the insertion on the spinous process, and the posterior tension band is absolutely not disturbed at all. And the moment your tube comes out, after your decompression, as you see here, the whole muscle space will just fall in and there is zero dead space. As you see, all the muscles will just fall back and fascia just approximates to itself, just requiring 1 stitch out there without any problems there. The size of incision actually in a simple single level microdiscectomy doesn't change much from a microdiscectomy. However, when you're doing a 2 level, 3 level or in a obese patient, I think the advantages are absolutely clear. With nil dead space, the advantages can be further bigger because without a dead space out there, and even in patients with dural leak, this is far more forgiving than any microlumbar discectomy. So this can be used as a dynamic procedure in spinal stenosis, in listhesis, in any case, in facet cyst, in disc, in migrated, up migrated, down migrated, obese patients. The size of the skin incision just remains the same. The morbidity of muscle damage remains the same as it is in single level procedures. So the advantages are plenty. It is a dynamic, reproducible procedure can be done. The learning curve of microdiscectomy can be utilized to do even complex procedures in lumbar, thoracic, and even in cervical spines, and particularly in dural leak cases with absolutely nil dead space. These are far more forgiving surgeries out there. The contralateral pathologies also can be dealt with by this tubular technique, which in a maculox retractor or a standard microdiscectomy may be difficult. Just some post-op MRIs, because there are many of us who ask whether you can really achieve same amount of decompression or not. You can actually see some very, very tight canals can be decompressed very, very nicely out there. You can actually do this in cervical spine also using the same principles as you do it in lumbar spine. Not only discectomies, foraminotomies, but also fixations, removal of tumors out there. This is one such case from C1 lateral mass. We did tubular osteoid osteoma removal without actually having to go and do an open case which would have required a grotesque amount of muscle dissection out there, particularly in front of the vertebral artery there. So all these surgeries can easily be done combining the benefits of minimal invasive spine surgery and tubular techniques and navigation, which is coming very handy. Another case scenario where a cervical facet boring was done using a tubular retractor, further reducing the fracture dislocation. So to summarize, the indication principles of discectomy are the same. The definitive surgery, which involves removal of offending fragment, gives the symptom relief, and that will not change, has not changed, and should not be changed, no matter what kind of technology that you use. Technical differences between microlumbar discectomy and microendoscopic discectomy are plenty. However, they all boil down only to the access part of the surgery, because the definitive surgery is the one which gives you symptom relief, and it doesn't change no matter what technology you use. Thank you, gentlemen.